Just like I hope everybody can hear me. Voice signal. Voice. Screen silent. Screen just screen okay. 5 seconds later. Okay. Mother then just okay. How do I know it's full screen? ఇక్కడ రాదు మీరు చేసి 5 seconds okay నేను ఎన్నిసార్లు వచ్చాను అందుకే okay start fine this is Dr. Jayanth. I'm the consultant pediatric neurologist at KIMS Cuddles. So today we are going to discuss the topic which has been given to me is approach to a floppy infant. So let's begin with this. So I would like to just give you a brief introduction about the spectrum of all the topics which I'm going to discuss. I need to see the slide level. I hope everybody can see the slides now. So today we're going to discuss the spectrum of etiologies causing floppy infant syndrome. The clinical history, important aspects, what all I need to ask in the clinical history. The examination findings, identifying the floppy baby is very extremely important to pick it up. And the approach, focused evaluation, that is the necessary investigations which need to be done. And I'll not go into the causes of all the causes of floppy baby syndrome in detail, but I would like to quickly review about spinal muscular atrophy, CMS, congenital myopathy, and CMD, and also a few management principles. So let's start with a case vignette. So this was a newborn baby on day 2, was referred to a pediatric neurologist with concerns of severe hypotonia. So on questioning, the history was significant. There was a history of third-degree consanguinity. It's always better to start the history with the family history than antenatal, perinatal, and postnatal. So this couple was a third-degree consanguineous couple with history of polyhydramnios and eclampsia. But there was no history of previous miscarriages, sibling death. No other significant family history was noted apart from this. And antenatal scans were all done. Triple marker was negative, and all the antenatal scans were nothing significant. So perinatally, the child was a male neonate born by LSCS, and because of the previous section, birth weight was 2.8. Then the child cried immediately after birth, and the child was kept in the NICU in view of hypotonia, but the sepsis screen was negative. On examination, the child had poor suck and hypotonia. So these were the only concerns from the neonatologist. On examination, there was no dysmorphism or any other neurocutaneous markers. On examination, there was severe hypotonia with absent reflexes. Rest of the systemic examination was within normal limits. So with this picture of neonatal hypotonia presenting at day 2 with hyporeflexia and consanguinity, the commonest, one of the common genetic disorders, that is SMA, was thought of, and an MLPA was sent for SMA. But MLPA came back negative. So MLPA is the screening diagnostic genetic test for SMA, that is multiplex ligation probe assay. So which came back negative. So there are a few conditions in the group of SMA wherein MLPA won't pick up. So the other causes of floppy infant were thought of because of the classical clinical presentation. And we have sent a whole exome sequencing. But whole exome sequencing also came back negative. So that logically rules out all the single gene disorders. And hence CMA was planned to rule out any chromosomal aberrations, to rule out microdeletions. But CMA also came back negative. So here, I mean, even though you have a clinical phenotype, which is pretty suggestive of SMA, I mean, it's not advised to directly go to genetics. So that's when you have to send a lot of ancillary tests, rule out other etiologies. So whenever you have a genetic test coming back negative, always revise your diagnosis before going to the next diagnostic test. And what's next after whole exome sequencing and CMA? Both of them were negative. So the next, the higher test was whole genome sequencing and reanalysis was thought of. But again, as I said, if you go higher up in genetic tests, I mean, before that, you have to rule out other causes as well. And baby improved spontaneously on day 3 and 4, which is like against all the genetic disorders which we were thought of. So after all testing, baby improved spontaneously. Then I think the history was looked out, and then serum magnesium levels were done, which came out to be 7 milliequivalent per liter. That is clearly high, and this was a case of magnesium toxicity. If you closely review the history, I mean, the mother had history of eclampsia. So if you see the pictures as given, magnesium is used as an anticonvulsant. So when there's a higher dose of magnesium in the mother, so there's a perinatal transmission. Magnesium easily gets transferred to the placenta. You can have magnesium toxicity. And if you see the adverse effects of magnesium toxicity above 6 milliequivalents, there is a column which mentions that there is hyporeflexia and hypotonia. So that is one of the treatable and an acquired cause of hypotonia. So the lesson learned from this case is that, I mean, even when you have a phenotype which is looking like a genetic disease, always rule out acquired and common conditions first before you go directly for genetic testing. And whenever you escalate your genetic testings, I mean, you just have to come back and rethink about your diagnosis. And if you still feel that no, it's still genetic, then it's better to go to a next genetic test. So with this case, we'll have a brief overview of all the causes of floppy infant syndrome. See, floppy infant syndrome has multiple causes. I mean, you have to think, I mean, identifying floppy baby is quite simple, but there are a lot of etiologies and syndromes which cause floppy baby syndrome. You have to know the list of it, because if you don't know the condition, then you will never suspect it. So the list is exhaustive, but you have to acknowledge the causes of floppy baby syndrome, which we'll be discussing in this talk in detail. And as I said, the history is extremely important when you're dealing with a genetic disorder, starting from family history, because in India we have a lot of consanguinity, and most of the genetic disorders we see in neurology are autosomal recessive, and the big chunk of them are autosomal recessive. So I think a history of consanguinity and a particular sect of community in India are prone to certain diseases because of the carrier status is too high in that community. So the community is important, the sect is important, and the consanguinity history is very, very extremely important when in approaching any case of a floppy infant. So after family history and a detailed prenatal history, that is throughout the antenatal period, you have to ask the history. And the perinatal history is also important. We'll get into the details of it, what exactly you have to ask specifically, and postnatal history as well. And apart from this, after a thorough history, there are a lot of clues which you get on general physical examination before getting into neurological examination. Like, for example, you see dysmorphism. So there's a saying which says that no, eyes are the windows to the soul. For a neurologist, pupils are the windows to the soul, and also for the neurosurgeon. But for a geneticist, dysmorphism is a window to the soul in diagnosing any disease which is pertaining to a genetic etiology. So a general physical examination, which includes a head-to-toe examination, which we usually overlook it. And after that, coming to a focused neurological examination, that is, we'll be looking at the various parameters which we see to assess the tone. So at the end of the examination, you will be able to decide whether the baby has hypotonia or not. If yes, then the next question is it central hypotonia or peripheral hypotonia? So we'll be discussing this in detail as well. And after making a thorough clinical history and an examination, you should narrow down your differential diagnosis of various causes of floppy baby syndrome. And after narrowing it down, then you should have a focused evaluation. I mean, you should not be doing a syndromic workup in every child who comes to you with floppy baby. I mean, at the same time, you should not be doing all the systemic workup as well. I mean, it depends on your clinical phenotyping. Based on that, you have to focus, the evaluation should be pretty focused. So that's why sequential testing is preferred over genetic sequencing. So these are the main four things you have to see after examining the patient and doing tests. Is it hypertonia or not? These are the questions. The second question is it if it's hypertonia, then you're dealing with central hypertonia or peripheral hypertonia. So central hypertonia is referred to as floppy strong by many authors, and the peripheral hypertonia is floppy weak. And after differentiating central hypertonia and a peripheral hypertonia, the next important question is where is the neuroanatomic localization? For example, if you're talking about a floppy baby with peripheral hypertonia, am I talking about anterior horn cell? Am I talking about neuromuscular junction? Am I talking about muscle itself? So the localization is extremely important. And after this, then the question comes, it's a congenital or genetic or acquired. So that is again based on the history. For example, the baby has illness which is starting on 15th day or 16th day, and the child was fine before that, or a baby presenting at birth. So there are certain clues where you have to think, is it congenital or acquired? So based on this, you have to plan your evaluation. Okay, so let's begin with the etiological spectrum. The list is exhaustive, so but we'll try in segregating different causes. So if you see before talking about primary neuromuscular disorders, so whenever we talk about floppy infant, the first thing which comes to our mind is spinal muscular atrophy or a congenital myopathy or a congenital muscular dystrophy. But we have to be aware that a lot of common neonatal conditions are associated with hypotonia. For example, any sick child, any CNS insult or any infection which is ongoing, the the neonate or an infant is going to have a transient hypotonia state. So that should not be misdiagnosed as a, a genetic or a primary neuromuscular disorders and test for that. So the common neonatal conditions are sepsis, torch infections, severe CMV sepsis, hypothyroidism, hypothermia, hypoglycemia, and maternal drug toxicity, as in our case, that is magnesium exposure. So these are some of the very commonly seen conditions. So these can definitely cause hypertonia in neonates. And any acute CNS insult, if you see HIE on a longer run, it is going to cause increased tone, that is spasticity, after a certain duration. But initial insult, you will have hypotonia. And in other insults like NHPI, that is neonatal hypoglycemic brain injury, IC bleeds can also cause hypotonia. Then common endocrine problems in neonate, that is congenital hypothyroidism, CAH, and hypoglycemia. If you see CAH will have other clues like hyponatremia, hyperkalemia, hypoglycemia. But you should think about endocrine disorders because they are much treatable. And after ruling out these common things, the next is genetic IEMs, because the combined incidence of IEMs in neonate is 1 in 1,000. So if you see, IEMs are not uncommon. And there are a lot of IEMs which can actually cause acute encephalopathy with hypotonia. So when you think about IEMs in neonatal age group or early infancy, so broadly, if you classify IEMs are can be classified as small molecule and large molecule, and you also have intermediate molecule disorders. So this is the typical Salisbury classification. So we expect a small molecule disorder presenting at neonatal age group, whereas large molecule disorders usually present later after 1 year, 2 years, and their presentation is quite different. They have dysmorphism, organomegaly. But if you have small molecule IEMs presenting in neonatal period, especially with hypotonia, you have to think about Pompey's disorder. That is one of the GSDs. And you also have other GSDs which can present with hypotonia, like Von Gurke, Anderson, and Corey. And organic acidemias can present with hypotonia and fatty acid oxidation disorders. In peroxisomal disorders, you have two disorders under this, that is Zellweger's and neonatal adrenal leukodystrophy. Both of them can present with hypotonia. And CDG is a very heterogeneous group, now very rapidly expanding. There are different types of CDGs, with most of them have a feature of hypotonia in the neonatal age group. But they also have dysmorphism. It is easy to identify that. So after IEMs, then the last thing before primary neuromuscular disorders, we should also think about genetic syndromes with hypotonia. So clearly on general physical examination, you will have a lot of other clinical handles. So before going into the rare microdeletion syndromes, I mean, you have to definitely identify the trisomies, which are much commoner. So trisomy 13 and 18, that is and Edward, respectively, will have a lot of other findings like rock or bottom feet, polydactyly, cleft lip, cleft palate, heart defects. But the commoner one, which usually tend to survive, is trisomy 21 Down syndrome, also has a very characteristic feature of hypertonia in the neonatal age group. So you have to think about genetic syndromes also, but you will have very good clinical clues in the examination. After thinking about all this, and finally it comes that you have to think about primary neuromuscular disorder. So this is the order it should be in, because the moment we think about primary neuromuscular disorders, then we rather miss the other common causes. So when you're talking about the primary neuromuscular disorders in the order of the neuroaxial axial localization, it could be a pathology in the anterior horn cell, that is SMA, spinal muscular atrophy. Then it could be the nerve itself. There are some variants of Charcot-Marie tooth disease, that is hereditary motor sensory neuropathy. The type 3 is known to present in the neonatal age group, so that's called Geraint-Sotas and hypomyelinating neuropathy. So those are the two types of CMTs which can present as floppy infant in the neonatal age group. Apart from Charcot-Marie tooth disease, and you also have congenital myopathies. So we'll discuss about congenital myopathies in brief in the following slides. But they do have hypotonia, significant hypotonia in the neonatal age group. And after congenital myopathies, you also have congenital muscular dystrophies and congenital myotonic dystrophy and congenital myasthenia syndromes. It is very difficult to differentiate among these causes, but we'll have a quick overview of all these in the end. So this is the whole spectrum. So I think we need to fit it in one of these and evaluate accordingly. So as I said, the list is exhaustive. So if you start with the neuroaxial localization, so first thing you have to see whether it's central or peripheral. So central hypotonia is basically called floppy strong because the lesion is in the brain and you have reflexes which are preserved. And there is floppiness, but the strength of the muscle is usually normal. On contrast to a peripheral weakness, that is floppy weak, wherein the lesion is in the lower motor lesion, the brain is usually normal. You have extreme weakness, you have areflexia. So this is how you differentiate floppy strong versus floppy weak. So if you go by the neuroaxis localization in the floppy weak, it starts with anterior horn cell. So anterior horn cell, as I discussed, the most common one is spinal muscular atrophy we think of. Then coming to the nerve, as I mentioned, that is congenital motor and sensory neuropathy, that is Charcot-Marie tooth disease. In that you have two particular disorders, because usually CMT presents in the first decade. You see that in children of about 5 to 6 years and 10 years around. But there is a variant of CMT, which is CMT type 3. So in CMT type 3, you have two disorders, that is congenital hypomyelinating neuropathy and Geraint-Sotas. So both of them can present in the neonatal age group with prolonged ventilator requirement. So that is about the neuropathies. And after anterior horn cell and nerve, coming to the neuromuscular junction. So neuromuscular junction, you have congenital myasthenia syndromes and also transient acquired neonatal myasthenia. So that is where you have to think about the maternal history. If the mother has myasthenia gravis, you can have a transient acquired myasthenia. And also like the drugs which we have discussed. So there are a lot of drugs which can actually act on neuromuscular junction. If you see an older infant or older neonate, aminoglycosides can have a neuromuscular blockade effect. And as we had discussed, magnesium toxicity can cause neuromuscular junction blockade. And another rare entity, which is called infantile botulism, also acts on neuromuscular junction. So that can also present as a floppy infant, but you will have some history of poisoning, and it's mentioned as contaminated honey in many textbooks. It's not pretty common. Then coming to the muscle itself. So you have in the muscle congenital myopathies, muscular dystrophies, and congenital myotonic dystrophy. So as I mentioned in this, the right side of the box. So these are the four primary neuromuscular disorders you should think of. I did not add CMT in this, but you should also think of CMT. So in the order, anterior horn cell is spinal muscular atrophy. Coming to the nerve, you have CMT type 3, that is hypomyelinating neuropathy and Geraint-Sotas. Then coming to the neuromuscular junction, think of magnesium toxicity, botulism, magnesium, and congenital myasthenia. Then coming to the muscle itself, think about congenital myopathies, congenital muscular dystrophies, and congenital myotonic dystrophy. So these are the entities. We'll discuss this in detail. So that is one approach. Another approach is, as I mentioned, cerebral anomalies will have central cause. So so whenever you're suspecting a floppy strong baby, it's advised to get a neuroimaging because there are associated cerebral malformations. So you see dysgenesis, you see cortical malformations, you see cerebellar cysts. So that is where you have to think about floppy strong. You have to get a neuroimaging in that. And on the other side of the spectrum, you have peripheral abnormalities wherein the MRI or the brain is usually normal. So in that spectrum, you have floppy weak causes. So this we have already discussed, that is anterior-hornsel nerve, muscle, and neuromuscular junction. So there's an overlapping entity which has both the phenotype. So in this, basically, there is peripheral neuropathy associated with a central nervous system problem. So this is typically seen in congenital muscular dystrophy, okay, Merosin negative congenital muscular dystrophy, and few other disorders like peroxisomal disorders. They have leukodystrophy and peripheral neuropathy, and other mitochondrial cytopathies. See, mitochondrial cytopathies, different types have peripheral neuropathy and a CNS involvement. So apart from this, as I mentioned, a lot of syndromes can have hypotonia as their presentation. So we have discussed this before, Downs, trisomy 13 and 18. And Prader-Willi is one of the most important things you have to remember, because if you see Prader-Willi, uh, the children have obesity starting after 1 year, but before 1 year, you usually have, underweight, and they usually are, on a lower side on the weight, and eventually they put on weight because of the hyperphagia. So in the neonatal and in the early infancy phase, you don't have obesity. You just have, failure to thrive and also hypotonia as one of the major features. Prader-Willi has a particular dysmorphism which is described, that is almond-shaped eyes, but it's not very specific, and it's not a good clinical handle. So this was the mentioning of neuroaxis localization. So whenever you have a brain abnormality, think of central hypotonia causes. For example, a child has a cerebral malformation, so that child can also have hypotonia. So when it comes to peripheral hypotonia, that is floppy weak, then you have to start thinking about all these causes like anterior hornsel, nerve fiber, neuromuscular junction, and muscle. So localization is also extremely important. So this was the exhaustive list of all the causes of floppy infant syndrome. So let's start with the family history. So as I said, family history, antenatal, perinatal history, and then developmental history. So this is the order. So never ignore family history. It's very extremely important. So let's see what exactly are we looking at family history. So first thing is history of consanguinity. As I said, India has a lot of consanguinity in various sects. So third degree consanguinity, that is amongst the cousins. So there's a higher incidence of autosomal recessive disorders when you have third degree consanguinity, because the chances of both the parents having the carrier status of that rare disease will significantly increase because when they have inbreeding. So autosomal recessive disorders, if you're thinking, history of consanguinity is extremely important. Then what is the significance of history of miscarriages? So whenever somebody says that, no, there's a history of recurrent miscarriages, the next question should be, is it an early pregnancy loss or a late pregnancy loss? Because if you see early pregnancy losses, that is early miscarriages within the first 2 months, in the first 3 months, it usually indicates a chromosomal anomaly. So that is the most common cause of recurrent losses in the early trimester. And coming to mid trimester, late trimester abortions, so that can be seen in autosomal recessive disorders or chromosomal anomalies as well. So that is one clue that we are probably dealing with an autosomal recessive disorder or a chromosomal disorder. History of sibling deaths again is extremely important in autosomal recessive disorders and also chromosomal disorders. Chromosomal disorders can also have recurrences because there are a lot of chromosomal anomalies which are inherited from the parents. So that can happen again. So there is the importance of sibling death also in chromosomal disorders, apart from autosomal recessive disorders. And the fourth thing important is, see, if you take a pedigree chart, I think it's a common misconception or a mistake that people do, that whenever we talk about pedigree chart, we do this 2-generation pedigree chart. If you see, as I said, autosomal recessive disorder is a big chunk of the diseases which we see in our clinical practice. But if you see this pedigree chart, you won't get any clues from this. So because most of the times, both the parents are going to be normal because they are heterozygous carriers. So if you have this pedigree chart, you will never diagnose an autosomal recessive disorder because even without consanguinity, there is a chance that the proband can have autosomal recessive disorder. So it's very important to have a 3-generation pedigree chart. So this is where it's important. You have especially ask for the disease if somebody has it in the siblings' children or the cousins' children. That is extremely important in an autosomal recessive disorder. And after asking that, can you guess why am I saying that handshaking the mother is very important? Consent, because congenital muscular dystrophy is autosomal dominant. It has trinucleotide repeat disorder. So if the child is suspected to have congenital myotonic dystrophy, so most probably the mother also will have a congenital or myotonic dystrophy. So in that case, you can elicit the myotonia with by asking the mother to shake a hand. So that is another important thing when you're suspecting a neuromuscular disorder in a baby. And as I mentioned, that ethnicity is very important, not only in India, but there are different communities in the world, like Ashkenazi Jews. I mean, we also have various communities which are known to have certain disorders, like neuromuscular disorders are very common in Agarwal community. So ethnicity is also important when you actually are suspecting genetic disorders. So these are the various points in the family. It's not a 2-generation pedigree chart. I mean, you have to ask all these things. They are very extremely important in narrowing the phenotype. Okay, after the family history, what all we ask in antenatal history? So, pertaining to neuromuscular disorders or a floppy infant, there are only few questions which you need to ask. But I think it's better to ask the entire list. I mean, starting from the first trimester, second trimester, every point in antenatal history is important. But the most important things in pertaining to floppy infant is fetal akinesia. That is late onset of quickening, and sometimes the fetal movements are not at all noticed by the mother. So that's called fetal akinesia or hypokinesia. That is the first important feature. Second important feature is polyhydramnios, because you know that a lot of neuromuscular disorders will have problems in swallowing. Because of that, you will have polyhydramnios. So that is a soft marker that we start thinking about a primary neuromuscular disorder. Third is malpresentations. This is again very common because there is fetal akinesia. So there is a chance that the baby will stick to the breech presentation. So malpresentation, polyhydramnios, and fetal akinesia, these are the 3 important markers of a suspected neuromuscular disorder antenatally. Okay. And apart from that, there are few metabolic disorders which can have soft markers on antenatal scans, like CNS malformation, choroid cyst, retinoid cyst. So anything like that, it's very important to document that. So that will all be important when you have trying to actually narrow down the phenotype before sending genetics. So these are the 3 points: akinesia, polyhydramnios, and malpresentations. Apart from that, as I mentioned, magnesium toxicity was one of the example. But apart from this, you have to take the entire history of maternal drugs, like ongoing maternal illnesses, like autoimmune conditions. What are the medications currently going on with the mother? And apart from the not very common in India, but illicit drug use is again an important cause for neonatal hypotonia, because a lot of opioids, a lot of other drugs can cause neonatal transient hypotonia. And as I mentioned, history of maternal myotonic dystrophy and eliciting the myotonia in the mother by shaking hand is also very important. So that is about the antenatal history and family history. Coming to perinatal history, malpresentation is an important feature, that is breech usually, and difficult labor, delayed and weak cry. So this is a feature of a primary neuromuscular disorder because of the oral and the phonic muscles being very weak. And the feeding issues, oromotor and pharyngeal weakness, pooling of secretions, and poor suck are very, very important to identify these. And when you start thinking of a probable underlying etiology when you have respiratory distress, but you don't know the exact cause, unexplained RD or unexplained neonatal encephalopathy, or irregular breathing. There's a paradoxical breathing pattern which is described in SMA and other neuromuscular disorders, because the intercostal muscles are more severely involved than the diaphragm. So there's a paradoxical breathing pattern and irregular respiration. And even when you intubate them and mechanically ventilate them, then it's very difficult to wean them off the ventilation. So that is when you should start thinking, we are dealing with an underlying genetic neuromuscular disorder. And as I mentioned, small molecule IMs like organic acidemias, mitochondrial cytopathies. They can also have unexplained encephalopathy and hypotonia. So that is an important feature in the perinatal history. So with this background, with thorough history in the family, three-generation pedigree, and antenatal history and perinatal history, with this background, before I examine, I should probably think, there's a history of consanguinity, there's a sibling death, and there is a similar child being affected in the cousin. So I start thinking before examining the child, I'm probably dealing with an autosomal recessive disorder with floppiness. So with that background, you just have a physical examination. Then you'll definitely know what to look at. So never miss classical dysmorphism features on the general physical examination, starting with Down syndrome. I know everybody will be able to hopefully identify Down syndrome. So you'll have a lot of clinical handles and physical findings in the dysmorphism when you are thinking about Down syndrome. I'll not go into the details. But apart from Down syndrome, you have common trisomies like trisomy 13 and 18, that is Patau and Edward respectively. You have multiple physical signs here. You have cleft palate, cleft lip, cutis aplasia. You have rocker bottom feet. All these are features of trisomy 13 and 18. Then there's another syndrome which is mentioned as down-like facies. If you see this second picture just beside the first one, Zellweger syndrome is mentioned. The classical dysmorphism mentioned in Zellweger is down-like facies, but it's not very specific. But Zellweger's is one of the neonatal metabolic disorder with dysmorphism presenting at birth. But they also have other clues like organomegaly and seizures, abnormal EEG, etc. So these are the one of the common syndromes we need to identify from the dysmorphism itself. Apart from this, another entity I was mentioning is CDG. CDG is basically congenital disorders of glycosylation. So this is a rapidly expanding genetic spectrum of disorders. So there are various type of CDGs and there are new genes coming up. So when you think of CDG is basically when you have certain dysmorphic features like inverted nipples, and abnormal fat pad distribution. If you see the lumbar fossa of this neonate, there's abnormal fat distribution. So abnormal fat distribution, inguinal hernias, and inverted nipples. These are the classical three markers described in CDG of any type. So always look for that when you're thinking of a floppy infant or a dysmorphic infant. So what do you see here? And this is a neonate with the extensive mongoloid spots. So when you have one or two large mongoloid spots in the lower lumbar region, that is usually mentioned normal. But you have a large or multiple mongoloid spots. There are few syndromes which need to be suspected in this, like GM1, GM2 gangliosidosis. So they can start having features in the early infancy, but this is one of the earliest markers you see and start suspecting. They eventually develop organomegaly and coarse facies later. And as I mentioned, one of the endocrine causes of hypotonia, that is CAH, you look for ambiguous genitalia. So we prefer the term DSD, disorders of sexual differentiation. So you have ambiguous genitalia, think of CAH. And in this picture, you see both mother and the baby being dysmorphic. In the baby, if you see, there's a long face in the mother, and the baby also has uh, a long face and open mouth. And if you see, the upper lip is inverted U-shaped upper lip, high arch palate. This is the classical description of a myopathic face. You can start seeing myopathic face as early as in neonatal age group and also in earlier infancy. So this is a family with the mother as well as the baby, both of them being affected with myotonic dystrophy. So this is congenital myotonic dystrophy. As I said, it's an autosomal dominant disorder with anticipation. That is, you have trinucleated repeat disorders, and with every generation, you have more severity and early presentation. So another important feature in molecular IEMs is basically a rash. So whenever you have rash in the neonatal age group, think of biotinidase deficiency. They can also have seizures and hypotonia. And congenital cataracts. This is a big group of disorders again presented with congenital cataracts. Start thinking of rubella, and coming to genetic disorders like you have Lewis syndrome and also galactosemia commonly, and even myotonic dystrophy can have Christmas tree cataracts. There are a lot of congenital causes. Start thinking of within these lines whenever you have a neonate or an infant presenting with congenital cataracts. So these are some of the important dysmorphic features I have discussed, but there is a whole list of things to be looked at when you're examining a child with a probable genetic disorder. So with a good clinical and general physical examination, coming to the focus examination neurologically. So on assessing the tone, so before going to the maneuvers, it's a simple assessment of tone wherein you have to check the passive movement of the joints. You start checking with the leg. So whenever you have a passive movement of the leg, you feel resistance. So normal tone is when you have a resistance approximately at 90 degrees at the legs, at knees, in the normal neonatal infancy. And hypotonia, you see, even after 90 degrees, there's no resistance. There's completely flexible. So that is the first clue when you're examining the tone passively. And the second thing, you have to see the posture of the baby itself. So if you see the posture of this baby, this is classically described as a frog-like posture. So if you see the hips are abnormally abducted, and if you see the posture of the hands also, and the flexion at the knees, they're abnormally flexed. This is the typical frog-like posture which is described in neonatal profound hypotonia. So apart from this, when you want to differentiate between central hypotonia and peripheral hypotonia, so the difference is basically both of them are floppy, but peripheral hypotonia, the strength of the muscle is also decreased. So the movement of the muscles, anti-gravity muscles, are extremely affected. So you have a floppy baby, absolutely no spontaneous activity and no reflexes. I'll think of peripheral hypotonia, that is floppy weak. Whereas when thinking of central hypotonia, you have floppiness, but the spontaneous movements and the strength of the muscle is relatively preserved, and the reflexes are relatively preferred. Then I think of central hypotonia. So it's very extremely important to differentiate central hypotonia versus peripheral, that is floppy strong versus weak. So then you have three maneuvers. So assessment of tone, when you have passive resistance, which is not there, think of hypotonia. And you have three important maneuvers when you're assessing tone. The first is pull to sit maneuver. When you hold the baby's hand and you slip from the supine position, there's a complete head lag, what you see. So what you expect in neonates and in early infancy is the baby tries to momentarily get the head to the straight level. In a few seconds, I mean, it's just momentarily. And the total head controls will start coming at 6 to 8 weeks. But if you have a complete head lag, start thinking about hypotonia. And the second maneuver is basically horizontal suspension. So when you put the child in prone position with your hand supporting the belly, if you see, normally the child tries to flex and momentarily tries to get the back to the straight line and also head to the straight line. Whereas if you see in this picture, the child is getting a shape of U, inverted U type of a figure, wherein the legs are completely extended and the hands are also not, extended and the head is completely lagging down. So this is a typical child with inverted U-like posture when you have horizontal suspension. The third maneuver you do is vertical suspension. You try to hold the hand from the armpits and try to lift. So in this posture, what babies do is basically they flex at the knees and also they have some sort of tone. It's very easy to hold them. Whereas we have a hypotonic baby, you try to the baby tries to slip off, and if you see the legs are completely extended. So these are the three important maneuvers you do to assess the tone. That is pull to sit, horizontal suspension, and vertical suspension. So this is a classical classification which has been mentioned since 2011. So this is an article by Dr. Van Toor from Stellenbosch University. So as I mentioned, assessing tone is very important. And the once you know that the child is hypotonic, the very next question is differentiating floppy strong versus floppy weak. Floppy strong is central hypotonia and floppy weak is peripheral, as I said. So if you see the description mentioned in this is floppy strong has increased reflexes. That is, reflexes are usually preserved. You have upgoing planters because you have brain being involved. So you have some sort of manifestation from the CNS. So for example, a floppy weak child, I'll take an example of the floppy weak as spinal muscular atrophy. Only anterior horn cells are involved. So when you ask the developmental history, it will be a predominant motor delay or motor regression, but all the other domains are going to be normal. When you see floppy strong on the left side, so you see here the brain is involved. So you do have a global delay or the cognitive domain also being involved. So the tendon reflexes are brisk or preserved. Planters can be extensor, and you can have spasticity. So you can have exaggerated reflexes. Global developmental delay is one of the feature suggesting floppy strong or central cause. So this is very important. And the typical features of shrill, weak cry are classically mentioned in floppy weak. Okay. Apart from this, there are more clues on clinical examination that we'll discuss in the coming slides, like tongue fasciculation. Where do you see that? So this was an approach which was proposed in 2011, that whenever you suspect a floppy strong child, that is you're suspecting a neuromuscular a CNS cause, then it is advised to do a neuroimaging, because you try to see the association, what is the central cause. So you get an MRI brain and look for the cause of it, like there is a malformation or is a HIE. And if neuroimaging is normal, then you think of other causes. Whereas if you see on the floppy weak side, the first investigation which you ideally get is CPK NAC, because there is hyper CKMA and a few neuromuscular disorders like congenital muscular dystrophy. But this approach is little, I think, outdated, because now we have a lot of steps being skipped. So I mean, invasive tests like EMG is only done in few situations, and we can directly go to genetics. We'll discuss that in the later slides. So this is the approach. So before going into the proper etiology by each category, I think we should have another case. So this case is a newborn on day 8 was referred with concerns of severe hypotonia and one episode of hypoglycemia. So on questioning, there is history of third degree consanguinity. So again, there is a background of consanguinity. I would think of an autosomal recessive disorder or uh, something of that sort. And with no previous miscarriages, sibling death, and no other significant family history and antenatal history. And triple marker was negative. Perinatal history, nothing significant apart from poor suck and hypotonia. These were the only concerns. On examination, there was no dysmorphism or any other neurocutaneous marker, which I have mentioned. The neurological examination only showed hypotonia and normal, but the reflexes were preserved. So I would like to put this in central, maybe central, or central mode of central cause, because the reflexes are preserved. And systemic examination, nothing was significant here. So with the clinical suspicion of neonatal hypotonia, that is floppy neonate, consanguinity, and hypoglycemia. So what is important here, hypoglycemia could be a probable clue for an underlying metabolic disorder. So a probable metabolic cause was thought of. I mean, but with this picture, I think hypoglycemia should be included in one of your clinical narrowing downs, because of this, we have considered metabolic workup, that is ABG, ammonia, lactate, everything came back negative, including GCM, STMS. So a small molecule IEM was relatively low on the list now, because the metabolic workup was negative. However, a whole exome sequencing was sent. And meanwhile, the report was awaited. The baby developed fluid and inotrope resistant shock on day 14 of life. So on revisiting, we have another clue in our clinical handle that there's probably some problem with the circulation. I mean, it could be sepsis as well. So whole genome sequencing came back with an identified pathogenic variant in GAA gene. So GAA gene is basically a pathogenic variant described in Pompe's disorder. So what we have missed in this case is basically uh, we had a perfect family history, we had a good examination, but we did not screen for other systems. So from this case, the learning point is that whenever you have a disease, uh, you're suspecting an entity, but it's also equally important that you have to screen for other disorders. So this child probably had an early infantile or neonatal onset Pompe's disorder, and there was early heart involvement. So 2D echo revealed dilated cardiomyopathy. I mean, hypoglycemia was one of the clue, because hypoglycemia is one of the characteristic feature in GSDs, and Pompe is one of the GSD. So 2D echo, if done earlier, would have picked up dilated cardiomyopathy alone. So that's why I said the focused evaluation should include multisystemic screening with high index of suspicion to whatever you're dealing with. So I'll just have a quick overview of all the clinical clues. I'll not go into the details of each condition. When you're thinking about primary CNS cause, like spinal dysmorphism, so the clue you'll get is usually you will have in the clinical examination, you'll have spina bifida occulta, or you have tucked up hair, and then you go with MRI spinal cord. With spinal muscular atrophy, you get a clinical features of tongue atrophy and fasciculations. So remember, tongue fasciculation is one of the important feature in any anterior hornsel disease. If you see an adult onset ALS, they also have fasciculation. And in children, I think for us, it's more of SMA, which is very important when you think of tongue fasciculations. Peripheral neuropathy, as I mentioned, CMT, early onset CMT type 3 can have peripheral neuropathy. And myasthenia gravis, you think of myasthenia gravis, neonatal myasthenia gravis when the mother has myasthenia gravis. So apart from this, we'll discuss these in individually after a few slides. So coming to the first disease, which I was talking about, is SMA. So the primary neuromuscular disorder when we talk about is anterior horn cell, the nerve, neuromuscular junction, and myopathy. So anterior horn cell, I'll just have a quick overview of SMA. We have four types of SMA, and type 1 is the Wernicke-Hoffmann disease, which is the most common one, which you usually see in the early infancy. So that is from less than 6 months. So type 1 SMAs will never sit. And type 2 SMA is basically Dubovitz syndrome. These children will eventually sit but never walk. Type 3 is Kugelberg-Melander, that is they walk. They have a late onset after like 2 years, and type 4 is adult onset SMA. So for us, it's like the floppy infant, the type 1 and type 2 sometimes we see as one of the presentations floppy infant. So they have other setups. See, on the right side, if you see the typical picture of SMA type 1, is you have predominant motor delay. You have poor head control, abnormal breathing pattern. They have early respiratory involvement. Mechanical ventilation might be needed. On examination, you get tongue fasciculations, and the onset is usually in the first 3 months. And there's a variant of SMA which is called type 0. They have fetal onset, neonatal onset, even more severe than type 1. Identifying SMA is very important because you have a lot of gene therapies available now, taking from gene replacement to splice site modifiers like Zolgensma, Risdiplam, and Nusinersen. So the earlier you identify, the better the outcomes. So coming to congenital myopathies. So when do I think of congenital myopathies? They have a typical picture in the neonatal age group. They have more of along with the floppy infant syndrome, they have more of bulbar weakness, and they also have facial involvement. So this is a clue that you're treating, probably dealing with congenital myopathies. But it's very difficult to differentiate congenital myopathies, congenital muscular dystrophy, and CMS. That's congenital myasthenia syndrome. So overall, if you see, congenital myopathies can be divided according to the histopathological findings. So back then, when genetics was not available, I mean, the diagnosis of congenital myopathy needed a muscle biopsy. So all these names are basically based on histopathology. So if you see congenital myopathy with cores, you have central core and multi-core and multi-mini core. So this is a histopathological examination. Then you have congenital myopathies with central nuclei, myotubular myopathy, and you have congenital myopathies with protein aggregates. So Nemaline myopathy is one of the commonest congenital myopathies in India. Then you have other diseases like actinopathies, CAP disease. So now these disorders do not definitely need muscle biopsy. We do genetics right away because we have congenital myopathy panels. So these are different types of congenital myopathies. Think of congenital myopathies when you have uh, predominant bulbar weakness, facial weakness, and oropharyngeal weakness and pooling of secretions, a predominant facial involvement. And they do usually have normal CK, and they do not progress. So that is one of the feature which differentiates congenital myopathy and dystrophy. Dystrophy is basically a progressive cause of muscle damage. There's an ongoing damage which is happening. So there's a progression in CMT, whereas in congenital myopathy, it's the same thing. I mean, the insult is already that there's a gene fault, and it won't be usually the progress. You'll have the highest involvement at the birth. So coming to congenital myasthenia syndrome, it's a huge again spectrum. I think I won't go into the details, but broadly you have to know that congenital myasthenia syndromes can be divided according to the gene, which is the proteins which are involved in different areas of the neuromuscular junction. If you see this diagram, the neuromuscular junction is composed of presynaptic terminal, you have synapse, and postsynaptic terminal. So there are various proteins which are involved in the transmission of acetylcholine from the presynapse to the postsynapse. So there are different proteins, and if these proteins have specific gene mutations, so they are called according with that name. So for example, it's called CHAT mutation, Rapsin mutation, Musk mutation, DOC7 mutation. So you can broadly subtype them into presynaptic CMS, synaptic CMS, and postsynaptic CMS. So this is how you classify. And this is also very important that we divide the group of CMS into presynaptic, synaptic, and postsynaptic because they have treatment implications. So in short, think of CMS when you have episodic apnea, vocal cord paralysis, stridor, trunk atrophy, and early onset contractures. For example, rapsin is one of the characteristic genetic mutation which has early contractures. They're present with arthrogryposis multiplex congenita. So these are few clues in the infantile period that along with hypotonia, you also have respiratory distress, which is not explained by respiratory cause and HIE. You have poor feeding problems. Then you have ptosis, facial involvement, ophthalmoparesis. So they start thinking of CMS. When you think of CMS, then the CK is usually going the creatine kinase is usually normal in CMS. So the next best test you do in CMS before you go for diagnostic genetic testing is basically electro-diagnostic test. So electrophysiology test can be done. So you have two options here. One is repeated nerve stimulation test, that is RNS, and the second one is single fiber EMG. So these are the two tests which are done to diagnose CMS. When you see a decremental pattern, so that is suggestive of CMS, and a single fiber EMG will also be suggestive of you're probably dealing with the CMS. So before going to genetics, I think electrodiagnostic test needs to be done. And we also have a whole panel of genes to be looked at CMS as well. And if you see, CMS also is an expanding spectrum of disorders. So we have new gene mutations coming up. So before you send genetic testing, you have to clinically narrow it down. So from the clues, we can probably isolate the gene as well. For example, CHAT mutation and rapsin mutation presents very early in the neonatal age group with episodic apnea and prolonged respiration, mechanical ventilation dependence, multiple extubation failures. So think of episodic apnea with CHAT and rapsin, and more of contractures again in rapsin. So even amongst the CMS, you can slightly have differentiation based on the clinical picture. So coming to the treatment, extremely important here is basically when to give pyridostigmine. So just remember, pyridostigmine can be given in a lot of CMS, but you have to remember where the pyridostigmine can actually worsen the child. So pyridostigmine is contraindicated in 3 conditions. So remember this, in the rest of the other conditions, you can give pyridostigmine. So the 3 contraindications of pyridostigmine in a suspected CMS is COL-Q, DOX7, and slow channel syndrome. So these are the 3 syndromes wherein administration of pyridostigmine can actually worsen the clinical phenotype, or the respiratory paralysis even gets worse. So COL-Q, DOX7, and slow channel. Apart from this, if you're suspecting anything else, you can give a trial of pyridostigmine. There will be improvement. So in conditions where pyridostigmine is not indicated, that is COL-Q, DOX7, slow channel, in this condition, you can try other agents like albuterol or ephedrine. So that is about CMS in short. And the final entity is congenital muscular dystrophy. Here, you just have to remember that CMD can be of 2 types. That is CMD with central nervous system involvement and CMD with no affection of central nervous system. So there's another classification. You can classify them based on the histopathological staining, that is merosin negative and merosin positive. So merosin negative myopathies are basically merosinopathies. So in this, you have to remember that CPK is elevated and it's an ongoing disorder. So that is how you differentiate CMDs from congenital myopathies. Congenital myopathies will have a static course. It's only one-time insult. You don't have elevated CK. In CMD, you have elevated CK. So that is more than 4 to 6 times. So in this, you have involvement of central nervous system. If you have a CMD, you always have to screen the brain. You have to get an MRI brain. And with CMD with typical CNS involvement, you look for 3 conditions here. That is muscle eye brain disease. That is second one is Walker-Warburg, and third one is Fukuyama. These are the 3 typical diseases which are mentioned in congenital muscular dystrophy with central nervous system involvement. Apart from this, you have other CMDs as well according to the gene name. Just remember, CMD will have elevated CK. There's a progressive course, and you can have CNS involvement, and you can have typical white matter involvements like leukodystrophy changes. So quickly about the principles of management in the floppy infant, trying to find out the cause is extremely important. For example, if you have diagnosed clinically and genetically diagnosed SMA, I think you should refer the patient to a geneticist for gene therapy, because we are seeing the scenario being very good for SMA. We have gene therapies being readily available, but still it's in the pipeline and it's very expensive. So apart from the particular cause being identified, the second thing is regular physiotherapy to prevent contractures. And we ought to, because any neuromuscular disorders, because of the paraspinal muscle weakness, you are prone to have scoliosis and you're prone to have hip subluxations. So annual orthopedic reviews must be done to screen for these conditions. And as you know that they have significant oromotor coordination and feeding issues, I think feeding assistance can be given with nasogastric tube and sometimes even gastrostomy. Avoid both underweight and overweight, because underweight, again, malnourishment is not good for the muscle tone as well as, but overweight also adds more weakness to the muscle. And they have, if you know that, they have a lot of problems with the respiratory secretions, pulling of secretions and coordination issues, oromotor coordination issues. So they're prone to have a lot of pneumonias. And that's one of the most commonest cause of mortality in these children. So annual flu and special vaccines like even for bacterial, so pneumococcal boosters, vaccines are definitely advised in these group of children. And the special group of congenital myopathies, you have to be very careful. And also neuromuscular junction disorders, special care during anesthesia is to be done. For example, these myopathy and neuromuscular junction disorders, they get exaggerated on neuromuscular blocking agents. So anesthesia must be very careful and used with caution. And sometimes, you have to use inhalation anesthesia, avoid neuromuscular blocking agents. And another condition, though rare, malignant hypothermia, is described in congenital myopathies, typically central core disease. So you have to avoid neuromuscular blocking anesthetics. It's a very difficult situation to handle. So that is about the management principles. To summarize, I'll just try to summarize everything. So if you have not listened to the entire lecture, I think this is where you have to get really uh, alert now. So identifying hypotonia is extremely important with frog-like posture and three maneuvers, as I mentioned: pull to sit, vertical, and horizontal suspension. You see the inverted U-like posture of the child. And with pull to sit, you have head lag. Okay, and frog-like posture is extremely important and easy to pick up. Quick family history with consanguinity, SIP deaths, and recurrent miscarriages to suspect autosomal recessive disorders and chromosomal disorders. Antenatal history of fetal echinacea, that is decreased movements, malpresentations, that is breech, and polyhydramnios. Perinatal history, prolonged respiratory distress, unexplained hypotonia, poor feeding are the clues, especially when you have oromotor involvement. On examination, look for myopathic faces, that is long face, upturned U-shaped upper lip, and high arched palate. Dysmorphism, extensive mongoloid spots for gangliosidosis, organomegaly for Zellweger's. Hypotonia, once you identify hypotonia, try to find out its central versus peripheral, that is floppy strong versus floppy weak. Then other systemic involvement is extremely important, like organomegalies you have in Zellweger's, cardiomegaly in Pompe. And also you can see cardiomegaly in mitochondrial disorders and fatty acid oxidation disorders. And exclude common causes before you jump to primary neuromuscular disorders. The common conditions like sepsis, TORCH, HIE, hypoglycemia, hypothyroidism, magnesium toxicity, and other drugs need to be excluded. And consider, only after ruling this, consider a primary neuromuscular disorder, that is localizing. Then after that, you have to localize along the neuroaxis. If I'm thinking about anterior onset, I'll probably see fasciculations. I'll probably think of decreased reflexes and abnormal NCB. I think of CMT. Then based on EMG findings, I'll think of maybe a myopathy, or the CPK is raised, I'll think of congenital muscular dystrophy. So localize after considering neuromuscular disorder is very important to neuroaxis localization. And with areflex and profound weakness, that is floppy weak, you have to consider EMG to rule out it's a myopathic or a nerve process, because suspecting SMA is very important, because as I said earlier, diagnosis, the earlier, better the outcome with gene therapy. Hyporeflexia, significant bulbar weakness, ophthalmoparesis, facial weakness, recurrent apneas, multiple extubation failures, prolonged ventilation. Think of CMS and congenital myopathies. CPK NAG, that is non-specified CPK CK, is usually normal in CMS and congenital myopathy, whereas it's elevated in congenital muscular dystrophies and congenital myotonic dystrophy. As I mentioned, amongst the CMS, COL-Q, DOX7, and slow channel syndrome, these are the three syndromes which pyridostigmine can actually exaggerate. So avoid pyridostigmine in these conditions. You can try other drugs in these, like oxygen. Apart from all these three conditions, other CMSs, you can give a trial of pyridostigmine. If central cause is suspected of a hypotonia, do consider neuroimaging to rule out associations like cerebral malformations or incidental, posterior fossa malformations, like any other association in the CNS. As I mentioned, focused evaluation rather than screening everything. I think you should have a focused evaluation, like, central hypertonia, you have to start with MRI. Suspecting a GSD, 2D echo, abdominal, USG abdomen to rule out any associated renal malformations, etc. And skeletal survey is also important in a lot of disorders, like, even Zellweger's adrenal leukodystrophy, you have stippling, metabolic screening. Enzyme assess can be done in Pompe's as well. So before you go to genetics, you try to get more of ancillary tests. So genetic testing should only be done after narrowing down, because it's very difficult for the geneticist to look for all the genes and to differentiate a polymorphism from a pathogenic variant. So I think the more number of information you give to the geneticist, it is more likely that they're going to give you a right answer. So only send genetic testing after narrowing down the DDs with meticulous clinical phenotyping and ancillary investigations MR spectroscopy or specific imaging findings for enzyme assays or GCMS TMS. Yeah, that is all. Thank you. Seven, 1 hour, 1 hour.